Well, hello and welcome to the latest in our webinar series. Today we're going to talk about PPE and the Joint Commission, the new Joint Commission standards, PPE and me. For those of you not familiar with NETEC, we are a partnership for preparedness funded by ASPR, setting the gold standard for special pathogen preparedness and response across health systems in the US with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. And we are made up of 13 regional treatment centers scattered across the country, and we have several of them represented today. NETEC has four big areas of focus: consultation and assessment, helping hospitals and healthcare facilities get prepared, training and education, things like today, along with an online repository of tools and resources. And we do have exercise templates and all sorts of things like that. And we have some in-person courses and a lot of online training. We have a research network, and we have some international partnerships as well. So today, I am very happy to be joined by some stellar folks from across the country. So I am Jill Morgan here at Emory University Hospital in Atlanta, part of our biocontainment team, part of the team that took care of our Ebola patients a decade ago. And I'm joined today by Brooke Henriksen, who shares the chair with me of the NETEC PPE working group. And Brooke is the training and education coordinator for the special pathogens program at Providence Sacred Heart in Spokane. We have Dr. Corey Levine, who's an assistant professor at UTMB, the University of Texas Medical Branch in Galveston, where she's also the associate director for their SPECTRE, which is their Special Pathogens Excellence in Clinical Treatment Readiness and Education unit. So glad to have Dr. Levine here. Sarah Heroth is from mHealth Fairview University of Minnesota Medical Center, one of the treatment centers in Region 5. And she's been a nurse for over 18 years and is a unit nurse educator for their special pathogens unit. Welcome, Sarah. And then Dr. Colleen Kraft, who's a professor here at Emory in Atlanta. She's an infectious disease physician, but she also serves as the Associate Chief Research Informatics Officer, and significant to her role for us today, she has been the president-elect, and then now past president of ASM, the American Society for Microbiology. And together, Colleen and I were on our Ebola team. So I'm happy to have all these folks with me today. And as I said, we'll get to as many questions as we can, and we really appreciate the questions that were submitted during registration. We're going to try to answer some of those as we go through our presentations. Okay, so let's talk about exactly what the Joint Commission says and doesn't say. So I want to point out, and I won't read this whole slide, but the standard is here and it's Googleable, as they say. And really what we're talking about is the request that facilities think about what they need to be prepared for the sudden presentation of somebody with a high consequence infectious disease. And while today we're focused on this new Joint Commission standard, we believe it reflects the interests and concerns for CMS. And so even though today is focused on Joint Commission, we think that is reasonable for people who are not necessarily Joint Commission accredited. So we have been in conversation with the DNV. I think that's one of the other large accrediting bodies, but we also think that it's good practice. So there are some facilities that aren't covered by this, even if the Joint Commission, if you're a Joint Commission accredited facility, this particular standard would not apply, for instance, to a psychiatric facility, a specialty surgical hospital, a long-term care facility. But that doesn't mean that you can't use the identify, isolate, inform model to help keep yourself and your facility safe. So where has this new admission been? I would want to know whether somebody's been bouncing, unfortunately, as some of our patients do, between hospital and nursing home and acute care and long-term care, because we know that they're more likely to be colonized with some things that can be dangerous. Or I might want to know that this patient who's admitting to my psychiatric facility has recently had travel or exposure to some other pathogen. So thinking about how we can implement these things, even if it's not a part of an accreditation standard, can help keep our staff and all of our facilities safer. And that this new Joint Commission standard covers more than PPE, but today we're going to talk about PPE. So it does talk about other things, and we'll go through a few of these, the identify, isolate, inform model in brief, but also it does mention infection control procedures and procedures for waste management, cleaning, and disinfection. So a very common question, what are special pathogens? So, we think of them as being sort of Ebola-like, but typically what we're talking about are things that are new, rare, emerging, for which there aren't good treatment options. They might not be easy to prevent. They might be very, very contagious. They might have high mortality or morbidity. And so that is what requires this special handling of them, because we want to do a good job of stopping them where they are, and by making sure that we've involved our public health partners to make sure that we can do the work necessary to, for instance, monitor other people who might be exposed. So generally speaking, we think of them as falling into some big buckets. Novel respiratory pathogens like MERS and novel influenzas that affect humans. Been a lot in the news lately about novel influenzas, some of which affect humans, some not so much. And then things like the viral hemorrhagic fevers, Ebola, Marburg, Lassa. And Nipah is sort of something we sort of lump in with viral hemorrhagic fevers, even though it's not strictly speaking a VHF. All right, so let's talk just for a second about the identify, isolate, and inform model. What are we really talking about? And what does the Joint Commission want to know? So thinking about how you will identify these patients early. Are you doing symptom screening at points of entry? Are you doing symptom and travel screening? How are you keeping up with these things? Like, do you have a method that, or a way that these things and countries are being updated? And we know that a lot of people are on electronic medical records like Epic, which has both standard and customizable options for what you're watching for. But one of the things the Joint Commission wants to know is, how are you training your staff on those things? How does your staff know what countries should be identified or what symptoms should be looked at? And then also, what happens when something is positive? So for instance, you're doing a symptom screening and somebody has both a fever and a cough. Well, what are you going to do in that case? Because we want to know what actions are triggered by that. So are you asking them to put on a source control mask? Where this occurs is going to be different in each of our facilities, right? Some people have a greeter that's going to be doing this. Some people have security. Some people have a triage nurse or somebody in registration. So figuring out who that first point of contact is, what questions they can and will ask consistently, and what happens to that information is really important. So we talked about actions taken. Well, one of the things might be thinking about, do I have a sick versus a well waiting room to put them in? Do I have a predetermined care space? Like I've said, this is the closest place that's appropriate for them in my emergency department. What PPE is available for those people? Like, can they offer a source control mask and then put on PPE of their own? Would you leave somebody in triage where you got something ready? For some of these special pathogens, we'd be talking about a fairly complex PPE ensemble. And you might not have time to put that all on before you take the next step. It might not be appropriate to put all of that on before you take the next step. So do you have pieces of PPE that you could use early to then perhaps stabilize the situation or isolate the patient in place until you can make something else available? We're going to talk about that more, and our other panelists today are going to talk about how they're implementing that at their facility. And then the inform piece, like who actually gets that information? And we want to make sure that we're not just fatiguing our infection preventionists and other staff members who might get pinged when these things go off. But what are you doing? What sets the plan in motion? So I think it's really important to think about at your facility, what's that next step? Am I calling my charge nurse? Am I calling my IP? We know that we're not quite at the point of saying that this patient is a suspect case yet, but we know that they've screened positive in some way. So while symptoms and travel together may mean a positive screen, determining the rest, like what kind of exposure somebody had, or how long ago they were in a country or exposed to some pathogen. There are a lot of other important questions that will need to be answered before we can decide that somebody's a suspect case. And we want to have them in a place where we've started to sort of control that risk. All right. Once we've done this, identify, isolate, inform, what happens next? We really want people to start thinking about what care can you safely provide? And we'll get into this a little bit more later, because this webinar in total is not about the complexities of providing that care, but we want to talk about the decision making so that you can put the important pieces in ahead of time. Because if you're going to think about offering laboratory support or an X-ray or a breathing treatment, what kind of PPE are you offering to those laboratorians and radiological techs and respiratory therapists? So we're going to talk about maybe inviting, making sure you have the right people at the table. What do your providers think that you can offer versus what your laboratorians think you can offer? And what needs to go into that decision making. So putting that into your head, that you need to be thinking about that in a system or a healthcare facility kind of way. All right, let's get into the meat of this today. This is probably the biggest question that people want to know. How are we supposed to document this? What do we have to do to demonstrate this piece of it? It's very important to understand that the Joint Commission not only wants you to have PPE, but to show that your staff have been educated and can wear it appropriately. Does that mean everybody in your department or everybody in your facility needs to? No. That decision is up to you. Whether you decide you're going to have a strike team or super users or everybody in your ER, that's a facility level decision. They want to know that you've thought it through and that you're documenting a level of competency. And so thinking about how your facility probably already documents competency when it comes to other high risk, low frequency skills. Do you let people get signed off every year on a defibrillator or an AED with putting their hands on it and actually demonstrating that they know how to do it, turn it on, use it? And that's probably the right method for doing PPE as well. At least you want to think about how you're going to be able to make sure that it's equitable with the other high risk, low frequency type skills. All right, so I'm so happy to hand this over to Dr. Corey Levine, who's going to walk you through the strategies that they've been using at UTMB and their PPE ensembles. Thanks, Corey.
Thank you, Jill. So I'm going to go ahead and show several of the PPE ensembles. I've included multiple options. These are both what we train other facilities on, as well as our own staff at UTMB. And I've included a lot of options because there are a lot of options and a lot of ways to implement this at your facility. I've tried to adhere to the CDC terminology as much as possible to make it clear. But if we can go to the next slide, we'll go through some of the options. So this is the first PPE ensemble that we use when training other facilities. So facilities that come to us asking to learn more about what PPE they should wear, get trained on donning and doffing. So this is for a clinically stable suspect case. So at this point, you would not have confirmatory testing, and they are clinically stable, so there's no bodily fluids coming out. And so we use either a fluid-resistant gown or coveralls, a face mask, a full face shield, and 2 pairs of gloves, with at least the outer gloves being extended cuff. Again, this would be for frontline staff, providing that initial care, going through that isolate and inform process. And then the other option for frontline is when you have a clinically unstable patient. They can be a suspect case, but they do have some bodily fluids coming out, or a confirmed case. So you know for a fact that they have, say, a VHF, Ebola, Marburg. So in this case, we recommend use of an impermeable gown or coveralls, an N95 respirator, head shroud, full face shield, 2 pairs of gloves. Again, the outer pair at a minimum has extended cuffs, as well as boot covers. So you're getting fairly good bodily coverage, so that if there are any splashes or contamination, you're covered from that. We do also utilize this ensemble for our frontline facilities. So we make what we call HCID, or high consequence infectious disease PPE packs, and they are assembled and stationed at our 4 emergency departments, our urgent care clinics, and our high frequency outpatient clinics. And within each of these packs, we usually station about 10 per facility. We include 2 laminated copies of the donning and doffing instructions, as well as contact information for infection control. And the reason for including 2 copies of the don and doff instructions is so that one can be placed on the outside of the patient room, and one can be placed on the inside of the patient room, so that the provider, when going in and coming out, has those instructions for reference. And then to make it easy for reorder and restocking within those packs, we also keep a supply list with ordering information for all of those items. So I'll move into our various PPE options for our biocontainment care unit or high-level isolation unit. So this is when we have a patient admitted to our unit. We've got several different levels depending on what pathogen we're dealing with, what procedures we are doing, and the confirmatory status of that patient with their disease. So to start, we have our low level. This is using an N95 for respiratory protection. So we have an N95 respirator with a full face shield, impermeable gown, a head shroud, boot covers, and 2 pairs of gloves, again, with the outer being extended cuff. Again, this provides great coverage, so that if there are any splashes or contamination, the body is protected. I do have a note in here that we do use shoe covers underneath the boot covers. This is not for protection. This is for ease of doffing. We found that adding that layer of shoe cover helps when taking off the boot covers, so that you're not taking your whole shoe off with it. So the next option is our low level with a capper or papper with a disposable lens cuff. This is when we need a little extra respiratory protection. This is typically what our laboratory staff use. They are working within a biosafety cabinet, so they have that extra layer of protection. And so for this ensemble, we use Max Air. We're also familiar with 3M and the other poppers. But on our unit right now, we have Max Air. And shown here is with the disposable lens cuff. We do also have the hood or shroud option, which can be used for specific circumstances, such as if somebody has a beard that's going to come outside that lens cuff, we're going to want that covered by the hood or the shroud. And then an impermeable gown, again, boot covers, and 2 pairs of gloves with the outer being extended cuff at a minimum. Again, we do have shoe covers on as well. This just allows for easier doffing. And then we do have a cap or head cover underneath our papper. Again, this isn't for protection from outside contamination. It's more for personal hygiene, and to keep hair from getting stuck in all the pieces of the papper. And finally, we have our upper level. So this is the one we would most often use in our unit when providing direct patient care. Again, if we have a confirmed patient, this provides the most coverage, and body is fully covered here. So we have, again, we use Max Air, but other options are also great. So Max Air capper with a hood or shroud, an impermeable coverall, an impermeable gown, So we use this gown on the outside just because it allows for, if you get gross contamination, for us to quickly remove it, put a new gown on. That way our inner layer, that coverall, isn't getting super contaminated. And then 2 pairs of gloves with, at a minimum, the outer being extended cuff. Same notes as before, shoe covers for ease of getting things on and off, and a cap or surgical cap for hygiene and keeping that hair in place underneath the capper. Next slide. I think those are all of mine, and we can go into some talking points about training later in the Q&A. Thank you.
Thanks, Corey. All right. I am happy to welcome Sarah Hera, from Minnesota, who's going to talk us through her PPE ensembles. Thanks, Sarah.
Thank you, Jill. I first wanted to say that all of our points of entry we chose to focus on initially was our emergency departments. So within my organization, we have 11 different hospitals. So we have a HSID cart in every single one of these hospitals. So the staff we chose to train, and this was really in partnership with our infection prevention staff really leading that work. So the special pathogen education team did support this, but it was really executed by our infection prevention staff. So they have a cart in every single emergency department that's nicely labeled. It's very clear what it is. It's got a binder in the top that says what you need, who to contact, and it's got the varying different things and checklists that they would need for their PPE. So these carts are in every emergency department, and we actually have staff complete a mandatory training, which is an LMS, and then they also have an on-site checkoff where they actually go through these skills on a yearly basis. So just kind of showing what that looks like. And then, so in that resource binder that I just highlighted at the bottom there, this is just some of the information we have for the staff that really lays out what do they need to do, who to contact, what those phone numbers are, and then in that order. So it does provide some reassurance and also education for these high consequence, low inference type of events. And these are checked on a quarterly cadence by our infection prevention staff as well. So some of the outfits that can be put together is, we've got a couple of different options here. So our level 1, so like Corey was referencing, these are for your clinically stable. So no one's bleeding, diarrhea, vomiting, and just hemodynamically, they look really good. So we also can refer to them as dry patients. So in our institution, we use a level 4 impervious gown. We have double gloves, and you can see we've got a very long extended cuff to really go up high, an N95, and then a face shield as well. And then we have our level 1 with a PAPR. So depending on how our employees fit test, or maybe they have facial hair, this is another option as well for them. So same thing, just a different type of level 4 gown, double extended cuff, and then we have the PAPR with the 3M system as well here. Level 2, this is when you've got a patient who's really sick or wet, so they're clinically unstable. We've got something coming out of an orifice, whether it's blood, vomit, diarrhea. It's nothing I want on my person, so I'm going to have the maximum coverage. I don't want any skin showing here. So I've got a level 4 gown. I've got double gloves. I've got an N95. I've got that surgical hood, which really is a little bit longer. And then we've got an apron. We've got our face shield, and we also have the same knee-high boot covers as well. So I don't want to take any of these germs with me. I want to be really well protected. And then we have our level 2 with the PAPR. So same exact ensemble. This PAPR shroud is actually double. There's 2 layers. So the inner layer is a little bit thinner of a mesh, and it tucks into the gown. So what you're seeing kind of on the shoulders is that long extended gown. So you've got really nice, the shroud. You've got really good coverage all throughout. And you always have a donning buddy. So that way they're going to make sure that you've put your items on correctly. You look good. Nothing's too long. It's not going to be dragging. It's really meant to be a team effort to make sure you are going in as safe as possible. Okay, and then our so Regional Emerging Special Pathogen Treatment Education Center. So we have two different things that we tend to use. We have our level 1, which is on the left-hand side, and then the level 2 is on the right-hand side. So historically, our team has found it much more comfortable to wear the PAPRs because we're in there typically about 3.5 hours at a time in PPE. N95s, we're very aware if if you've gone through COVID, it's not something you want to be spending a lot of time in. It's very uncomfortable. And our lab staff also uses our level 1 PPE with the PAPR. So that is what they use. And then if our staff we've got a really sick patient, then we are going in there with the booties and also the apron.
Thank you, Sarah. Okay, so now most of the ensembles you've seen so far have been about doing direct patient care. So nurses and physician providers or other providers who might be in your emergency department. We want to spend a little time. I'm happy to have Dr. Colleen Kraft with me today to talk a little bit about lab considerations and laboratory PPE. So, Colleen, thinking about what labs a facility, a frontline facility, a hospital that's presented with one of these patients, what labs might they want to think about being able to offer?
So of course, it's going to be patient dependent, but we don't really have infinite number of labs that we use to actually evaluate people when they're very sick or when we're concerned about their presentation. So I would say, we end up doing the typical basic metabolic profile. We tend to end up doing a CBC, and we may do a venous blood gas if that is helpful, depending on how sort of acutely ill they are.
All right, and how then can we do that safely without contaminating our labs? Where does that actually happen?
So of course, the answer is that it happens in the places where your institution actually has decided proactively, which is probably why you're on this webinar, to actually decide where you're going to do testing for somebody that may have a pathogen that you do not want transmitted to any of your staff. And so what we end up doing is doing an independent, sort of risk evaluation. And, when I first heard the term risk evaluation, I also thought, that seems complicated, but really, as you're looking at this slide, these are the questions that you can ask. How do you obtain these things? How do you package them? We really want high reliability. I think that's one of the other standards of NETEC is that we never want to make a mistake when we're taking care of these patients. We never want to expose somebody that doesn't need to be exposed. And so I think, that starts at the bedside. So how is the laboratory drawn, and who's going to draw it, and who feels comfortable drawing it? Because these are things to decide before you actually end up having to do it in the room. Even if you just go through a small risk assessment and a small, just sort of, kind of scenario, and then you'll figure out, okay, where do they need to go? So, a lot of people value point of care in their emergency departments or have that ability. So getting everything done in that room does make a lot of sense. And then I would leave everything in that room until you make sure that you're not still concerned about a hemorrhagic fever. And then obviously anything that's going to protect any aspect of this collection. So especially when you're doing in the room testing with like an iStat or whatever, you want to make sure that that person there can be sharps, when you're drawing blood, that's also a huge risk for transmission. And so who's going to sort of do each part of those? And it's always a good idea to have a buddy and somebody watching to make sure that these things are handled well, that somebody, if they need coaching out of a situation, that they have sort of a buddy that can help them.
Yeah, I think the idea of being able to do what you can at the bedside is fantastic. So if you have access to something like an iStat, certainly not a promotion for iStat, but something like that, great. Otherwise, if a lab decides that they can run something, or maybe they've got a device that they can use that isn't used and can take down their whole core lab, we're used to bedside clinicians PPE. How do laboratorians decide on PPE when a lab coat and gloves just aren't enough?
Yeah, that's a great question. And I think early even back to 2009 H1N1, we are thinking a lot about that. So you want to really always think about your abundance of caution. You want to think about the things that you're actually doing. So, I think we can all look at a standard operating procedure and say, these are the things that I do in my work, but you want to think about aerosolization of your of what you're working on. You want to think about if it's in a room with 10 other people. You want to think about, so these are, what we call administrative controls, environmental controls, and these are all part of a typical risk assessment in any laboratory. So long before there were the things that we're talking about today in this webinar, there are things like hepatitis B and HIV, hep C. And so we have traditionally done risk assessments for bloodborne pathogens very, very routinely. And so you want to just sort of expand that to say, what about what I do and what about what I'm wearing will completely prevent me from getting any sort of exposure to these tests that I'm working on.
Excellent. All right. And then I just want to make one plug for what we commonly find that people who are ill and perhaps have traveled, that they, at least in my experience, have had, and that's malaria.
Right. So malaria, again, I am not, purporting any specific kind of, test or any company's test, but really having a rapid malaria antigen helps so much. We've actually managed to misrun our own antigen and having to do it a couple times. And I think it's still the most important thing to rule out in our individuals that are returning travelers from these areas. So this is something that needs to be a part of your barrage of testing.
All right. So I think that, to me, when people are thinking about the PPE and their ensembles, and they also need to be thinking about these conversations and making sure that your ER providers and your laboratorians are on the same page with what labs you can and can't offer. What's a send out? How would that send out happen? So can you talk for just a minute about how people would actually do the diagnostics for some of the pathogens we're talking about?
Sure. And I want to make sure in terms of what they're going to wear or where they would do the diagnostics, just to clarify with you.
Well, I think that we know that most places won't be able to do these diagnostics. So maybe start there and then.
Right. So if you're going to be sending it to a state laboratory, then you're going to be thinking about your chain as to how you're going to transport that next. So again, I view this as a scenario that you sit down and do with the leaders in your institution, or the frontline group in your institution that will represent these areas, and talk through drawing a special pathogen. We already talked about the bedside. There's a risk there. Most of the laboratory, we can contain and completely prevent our risk if we're actually wearing the correct PPE. And that needs to, again, as Jill's already mentioned, be agreed upon by all sort of stakeholders. And then, sometimes at Emory, we did where lab PPE is the same as clinical PPE, just because we didn't want to have to memorize different versions of it or have to worry about that being different. That may be different at your institution. So then there's the aspect of packing that up. At your institution, usually there's usually an suspect category A, meaning one of the things we've talked about on this viral hemorrhagic fevers and other things, can still be shipped as category B, but you need to make sure that that's correct in your local area, and that you have sort of a good shipping and reliable method to take those to the next place. So again, every part of it is about, you're not going to just throw it in the back of a truck. You're going to put it in a box, maybe a couple bags, and make sure all these things are protected so that you don't have any accidents with these types of labs.
Thanks, Colleen. All right, we're going to move on to how places are going to implement these. So next slide, please. All right, so Brooke Henriksen is going to talk to us about strategies for implementation.
Thanks, Jill. I think one of the most common questions we get when we start talking about PPE in the new Joint Commission, not only just about how do you define competency, but how do you even get started? And I think this has been a great conversation. You've been able to see other facilities' approaches to their PPE ensembles. And I know we're all at such, we're subject to what our supply chains are able to get for us. So we really hesitate in recommending any particular PE ensemble or brand just because we don't know what you're going to have available. But making sure that when you do decide on your ensemble, does your team know where they are? Where is that PPE? A lot of us are so used to getting into our regular isolation standard PPE, and we know exactly where that is for our facility. It's the yellow cart, but that may not be for this type of PPE. So knowing where your team is going to have that, I know that Sarah discussed having those carts, which can be great, and then they can just grab the cart and take it to the room. But maintaining also within that cart, is all of your PPE up to date? They tend to expire pretty quickly. And then so you're going to have a rotation process. Initial training on this, I think we can take a lot of different ways, a lot of different approaches to this. We've partnered with our professional development team, and we now add with our new hires into our ERs, we add a short 1 hour, 45-minute discussion around identify, isolate, and inform. Let our new caregivers know where those resources are, and then they quickly get their first hands-on of putting this PPE ensemble on and taking it off. That's one approach we've used. And then we've also partnered with our professional development, and we have attended different skills trainings for our ER department or skills fairs. And it's a really quick half an hour touch base with those caregivers during the skills fair, where we really quickly review again the identify, isolate, and inform, where they can find the resources in their particular department, and then they actually put on the PPE and take it off. We have been able to attend those yearly for the last couple of years, and they have been very valuable to our caregivers. And then figuring out your cadence. I think it's been nice that the Joint Commission has not been too prescriptive as far as how do you define competency, but I think it's left a lot of people questioning how you do that. So we've opted to go yearly. We have an online course as well to kind of help touch base with people if they want to have a little bit more education. It's a video with a little touch base. But I want to bring in some of the other panelists and see what strategies have you guys used to help implement some of your Joint Commission standards or some of these new identify, isolate, and inform with your PPE ensembles? How are you getting that message and that education to your staff?
So I can go ahead and start here. We're starting with a broad sweep. So we have a module that we are including in our annual online training. So this will go right along with all of the other isolation procedures and those ensembles. We have both a PowerPoint slides with that information, and then we also did some filming to show the various steps for donning and doffing, some common mistakes, and things to look for. In addition to that, our clinical nurse educator is going out and doing short virtual information sessions with our emergency department staff, our labor and delivery staff, our outpatient clinics, and our urgent cares. And she's going through the identify, isolate, inform protocol, as well as giving examples of how to do a travel and symptom screen, what a BPA firing will look like, and what the next steps are when you see that BPA or that alert fire. So we're starting with hitting everybody with all of that basic information. And then from there, we start to step up on who actually receives hands-on PPE training. We do like to work on both a train the trainer model and a super user type model, where we have individuals who know these ensembles, know how to don and doff very well, and can step in at any point. Our infection preventionists are also very familiar with the procedures, and they should be the first call and are down there immediately to assist.
Thanks, Corey. Sarah, what approaches have you guys taken to implement these standards?
Yeah, thank you so much, Brooke. We probably started even before the official word came from the Joint Commission that we were rolling out these standards. So our infection prevention team has really been working with our EPIC team to build an out-of-the-box screening tool. So every patient, regardless of where they go within our healthcare organization, clinic, urgent care, ED, it could be any L&D for an assessment. They're going to answer their travel screening questions. It's built into the system. It's then they're going to be asked the symptom questions. What happens on the backside is those two cross-reference a list that we have hidden. And so no one sees it, the registrant doesn't see it. And if it matches to like, oh, it could be something funky, it's going to flag a best practice advisory. And it will tell them exactly what they need to do, whether it's, grab a triage nurse, tell them that very next step. And from that point, it's figuring out, like, especially in emergency departments, there's not a lot of space. There are borders. You're bursting at the seams all the time. Okay, if I don't have a room I can put them in, just put them in a room separate, close the door. Something I can do to isolate them, but still giving them that ability to reach out and be contacted. So we first started with our identify, isolate, and inform process. And then we rolled it out even bigger to the system. So we really then focused on our emergency departments because we knew that's primarily like our biggest bang for our buck. And we educated all of our emergency department staff. So it was physicians, our emergency techs, we had our nurses, we had just anybody who was there. And it was our infection preventionists. Every single month was one ED, and it was Monday through Friday, and the shift changes, and it was about 2 hours on each end. It was a lot of time. They were also supported by our practice and education team, so our education department, and we helped out the best we could in terms of like what we were able to offer for support. But it was manually checking everybody off, grabbing people off the floor, having people actually get checked off, show us that they're comfortable and competent to safely care for it. And that was the physical training that we chose to do. They also were assigned an online learning module, and that specifically had them choose, I work at this hospital. And they would choose that, and that would show them their exact cart and tell them exactly where it was located. For our new folks coming on, it's a part of their onboarding process. And so there really was a lot of work that we really wanted to make sure that our teams who are most likely to encounter these patients are set up for success and feel confident providing that first response.
Yeah, such great work. And I think it just goes to show, because I think we're all seeing high turnovers in our ERs. There's just a lot of turnover. So I think having, we've all talked about super users, which are so important to have those people in your ERs or in your departments that are really familiar, because touching each and every individual in your ERs can be difficult. As you've said, Sarah, that was a lot of time that it took. And so I think trying to manage that and trying to find a system that works within your facility, whether you have those super users, which I think are very valuable, certainly engaging your infection prevention departments to help with that. But I think it's also so good to try to touch base with those new caregivers as they're coming on, so that this is just a standard from the get-go, that they understand how your facility is taking its approach to this, and they get it right in the very beginning. Great work. All right, next slide. I think we are ready for questions.
Excellent. Well, thank you guys so much. I think we'll try to dive into a few questions. Some of these we got during registration, and some of course we have in the Q&A. So thanks. Please continue to submit those. I want to cover just a couple things. I want to, since I have 3 other regional treatment centers here, just ask if any of y'all make any change to your PPE ensemble or anything you add. If you had somebody, for instance, who was a grubby-handed toddler, or delirious adult, or anybody else who might be a danger to our PPE. Are there other things you want to think about with that?
I can certainly offer. So we are a treatment center that does not utilize coveralls. And the reason we chose not to use them is we cannot safely doff them without contaminating and really being safe to get everything off. And so some of the things that we think about, and especially when you've got a young kid. I've got young kids myself. They are constantly grabbing at things. And so the biggest thing I want to do to make sure that my staff is well protected and I'm well protected is kind of reevaluate. So we will utilize masking tape to secure our gloves, our first layer of gloves underneath, to make sure those do not come off when we're either changing gloves or someone happens to grab onto us. And that's also really why there's nothing wrong with putting an extra layer. If you've got someone who's got maybe dirtier hands, like a young kid, or, just something that kind of help that slide off, maybe an apron will kind of help slide that off. So if they do grab a hold of you, they're going to tear that off and not my actual gown that's protecting me.
Excellent. Yes. So I think the use of extra layers, having something that maybe a kid could play with or grab a hold of and not damage the rest of your PPE is really a reasonable thing to think about. Corey, I know you have a young one. So when you think of all that get into at the house, what do you do with your PPE to make it any safer?
I mean, additional layers definitely help. Again, with us, we do include that that gown on the outside of our coveralls so that we have another layer. I think your suggestion, making sure the patient has something to hold on to and fiddle with instead. I've also heard, if we're talking pediatrics, some utility in dressing up a teddy bear or some sort of doll in PPE. It can help the patient get more familiar with it rather than having a scary adult come in. And also, again, it gives them something to touch and play with while you're doing what you need to do. My one caution,
Yeah.
my one caution with additional PPE is that it will restrict your movement more. And so anytime you're thinking about layering up, being an extra pair of gloves, an extra gown, even extra set of boots, make sure you check your range of motion, because the last thing you want is to get in there and not be able to lift your arm more than a couple degrees, or all of a sudden you can't feel through multiple layers of gloves. So if that's the way you're thinking, definitely practice in it first.
Yeah. No, I think that's a great advice. And I think practice in it first, of course, is sort of a theme for all of this, right? I mean, what competency, making sure that you're giving people an ensemble that they're capable of wearing, that they're capable of doing their job in. So super important that you don't get overheated, that you still maintain your ability to see. And I want to just pivot that a little bit to a conversation about where you take things off. And I want to point out, I don't think we mentioned this, but I want to make sure that people are aware. We do have not only the ensembles, but the actual step-by-step protocols for donning and doffing, both for this webinar and the previous webinar we did on this same topic, where we had 4 or 5 other regional treatment centers that also presented. So those are available for you to do some benchmarking, for you to look and see what format or what steps you like, and that you can sort of pick and choose among those. And we know that doffing really is very dependent where you do what step, depends on what your infrastructure looks like. Do I have a curtain? Do I have a door? Do I have an anteroom? Am I in negative pressure? Am I not? So we can't go through all of those iterative differences, but we can talk a little bit about like cleaning. PPE becomes a lot of trash. So let's just talk for a second about what we do with all this stuff when we take it off. So let's see. I know there were some questions about PAPR like cleaning and decontamination. So Corey, I know you guys talked about your particular PAPR, and it's obviously going to differ by PAPR manufacturer, but can you just walk through the one you showed us?
Yes, so we are currently using the Max Air Capper. Again, I'm not endorsing any specific brand. Work with what's available to you and what's comfortable for your staff. But with the Max Air Capper, there is a hard plastic helmet as part of it. And so that is reusable. That, the cord, the battery, the belt, those are all reusable. And so those we disinfect with an improved disinfectant such as Cavicide, Cavi wipes. And then the disposable parts, so be it the disposable lens cuff, which will be sort of a face shield and the cuff underneath, that gets disposed of immediately afterwards. And same with the full shroud unit that goes over and down and most likely under your gown or apron. That is also disposed of after use. And those are meant to be disposable. They come in 50, 100 packs. They also have different sizes. So again, the helmet is adjustable, but the lens cuff, you'll get 2 different sizes, depending on your face.
Thanks. And then, so when we're disposing of all this PPE, we're taking off things that are single use. That makes a lot of trash. So, Sarah or Brooke, can you walk through like what gets taken off where? And maybe I'm looking for a phrase that I know you guys are both familiar with, like this principle of removing things.
I'm sorry, could you repeat the question? I was reading something in the Q&A.
No worries. No, thinking about like where you take things off. So what are the principles of doffing that we want people to sort of get, that you're going to start someplace and what becomes of all this trash? Where is this all going?
Yeah, I think so much of that depends on what you said is on your infrastructure. So some of you may be doffing in the hallway because that is your opportunity. Some of you may be doffing, if you have an ante room and you're lucky enough to have that, you may be doffing in your ante room. I think the most important thing about a doffing process, and I'm not sure if this is quite what you're looking for, Jill, but is to definitely have a very structured process where you have a trained observer who's walking you through step by step which piece to take off next, what to do after that, now which piece do we take off, and maintaining that slow, deliberate process so that you don't have somebody kind of just quickly flinging things off and taking them, potentially contaminating them unknowingly as they are quickly removing PPE. The one thing we really strive to say in our PPE doffing process is this is going to be slow. This is going to take you a lot longer than what you normally do. And so please be patient and follow the instructions of the doffing assistant or the trained observer, I should say.
Yep, I like that. Sarah, anything to add to that?
Dirtiest thing comes off in the room. So it's always going to be I say you're never wrong to do hand hygiene. And it's counterintuitive in a lot of things to do hand hygiene on PPE, but you do it on your gloves before you take them off. You're really trying to reduce the risk of bringing anything out with you. I don't want to bring home ooey gooey things to my family. So if I've got really dirty gloves, hand hygiene, take them off in the room. It's constantly thinking about those infection prevention practices, cleaning the door handle before I exit, making sure I've got everything good and disinfected. And then I'm taking off, making sure that I don't have any contamination on myself. My doffing partner is checking me out as well. And it's really meant to be a slow, methodical process. It's just a team effort.
Yep, I agree. And I'm glad you guys both emphasized sort of the importance of an observer, the importance of being methodical, and that whole idea of like dirtiest first. Like, what can I take off that's now going to reduce my risk as I take the rest off? So getting rid of the dirtiest pieces first. Obviously, if you've got visible contamination on you, I normally don't like that phrase, but you know what I mean. Visible contamination, you might want to take that off or remove it with like a wipe. And then, as Sarah said, we hand sanitize through our doffing process all the way through. And so I think those things that we want to make sure that we're not spreading risk anywhere, that if we can leave it in the room, we're going to make it safer for everybody. I know we've only got a couple of minutes left, so I want to ask our panelists, do you have a question that you've seen in the Q&A that you definitely want to just get out there right now? Otherwise, I want to tell people, so be thinking about that. I want to tell people that we will be putting together a NETEC blog, a blog on the NETEC website, hopefully answering as many more of these questions as we can about PPE, about cleaning PAPRs, and about all these other questions. So please look for that, and that these slides will be available on Tuesday with this entire recording available later this week, and that there are a number of resources on the last couple slides that will direct you to both protocols and guidance from places like the CDC. So with that, does anybody have any questions they want to answer quickly before our time is quickly closing?
I do want to answer just, I did just write about it, but we do know that every place needs to do their own risk assessment for the laboratory. So we're not saying that the only two places you can test the labs are at the bedside or in a special laboratory on site. You can send them out to a public health laboratory, and also you can also work with your own clinical laboratory, but a solution needs to occur before you just put them in the line with sort of other labs without letting the laboratory context know.
And I would just say, if these patients come in with family, friends, they also need to be screened. So asking them their travel questions, are they symptomatic, and treating them as such and isolating them as well.
Yes, your public health folks might want to have a word, right? Depending on what happens next. And keep in mind that you might want to sequester your waste. We really don't have time to talk about that much today, but all of this waste that if it's potentially contaminated, you should hold on to until you know whether this patient actually rules in or rules out for a special pathogen. Some of our special pathogens, but not all of them, would become category A waste. So really important to think about. We are in the last minute of our webinar, and I just want to thank our panelists today. I want to thank all of you for attending. It's just so important that people take action and get prepared, and we really appreciate having the hundreds of people on this webinar that we have, and we appreciate that you're doing what you can to help your facilities get ready. So thank you to Brooke and Sarah and Corey and Colleen, and to the folks behind the scenes at NETEC, and please visit us at netec.org. And if you have additional questions, you can submit them at info@netec.org. Ask for help of any kind, and we'll get back with you and try to get answers for you. Thank you, guys. Thank you all very much. And that concludes today's webinar.